Minister.
Thank you, Honourable Speaker. I am proud to stand in the House today to present the estimates of the Ministry of Health. Honourable Speaker, this is vote 29. Be it resolved that a sum not exceeding $17,820,760,000 be granted to Her Majesty to defray the expenses of Ministry of Health ministry operations.
Just to confirm, that is an increase, I understand, of $522 million from the restated estimates of last year, and that represents an annual increase of approximately 2.9% year over year. Is that correct?
The increase is approaching 3% at $522,494,000. I think the member's point is that the annual rate of increase in health budgets has decreased over the last 3 years, which is very in line with what is occurring across the country.
Thank you. So health spending is anticipated to rise by about 3% a year for the next 3 years. How does that compare to the rate of inflation?
The current rate of inflation is approximately 1% per annum, so it is 3% or 3 times the rate of inflation.
Thank you. What is the anticipated increase in population in BC as a percentage year over year?
And population, we estimate the pressures due to population growth is 1.2%, and the other pressure related to aging is 0.7%. So we do try to take those factors into account, not just the growth of the population, but the demographics of the population. As we have talked about many times with our federal counterparts, British Columbia has an older population, and as that baby boomer generation moves through the system, it does put added pressure on the system.
We're talking about health care. The Minister has confirmed that the increase in the health budget is 2.9%, 3%, roughly $522 million increase. That health care inflation, the Minister estimated to be approximately 2%. He said, and of course he's right, that inflation in healthcare is not the same as a basket of goods as calculated under the CPI. The Minister has indicated that the aging population accounts for 0.7%. CIHI actually says 0.9%, but even if we take the Minister's figure of 0.07%, the aging population, the population increase, the Minister referred to as 1.2%. Now, that means even without getting into the Minister says $160 million for the new nursing positions, from which you would have to deduct various things, I understand, but deducting figures that are not yet known yet and not yet proven yet. We also have an additional $72 million budgeted for pharmacare. And so even without getting into the increase to ambulance service and MRIs, it seems to me that the commitments that have been made and the expected increases because of aging population, because of population increase, because of health inflation, already has eaten up more than the entire budget increase that the Minister has projected. It is very difficult to understand with those announcements, with those additions, and with those costs that the Minister has agreed with, how the Minister could not be planning to make some significant cuts in various healthcare programs in order to pay for those expected increases and those new programs. What is the Minister planning to cut in order to meet the budget?
Minister.
The reality is we understand that to have a sustainable healthcare system, you do have to change things. And so when Fraser Health, for instance, says we've got too many people sitting in what we call alternative level of care beds in our health authority, we are going to create 400 new beds in community for complex care patients in residential care. But we're going to close 78 or 80 beds in the acute care system, those alternative level of care beds. That will result in A, better care because they're in the appropriate environment, and B, savings, because each of those acute beds, the alternative level of care beds in an acute facility, will cost on average 4 times more than a bed in a residential care facility. So the member's contention is that we just keep doing the same thing rather than changing. And I know the member has read all of our strategic priorities for the healthcare system. This team worked extremely hard for over a year when we came into the ministry in June of 2013 to develop the strategic priorities. And those priorities address the need in an aging population to do things differently, to look after people in their homes longer, to provide help in community, so that would be assisted living in residential care, so that we're not as reliant on the high-priced acute care facilities that were really built for a younger population and a style of medicine that was more suited to the 1970s than it is to the 2016. So I would contend that by having a 2.95% increase in our budget and making the changes in the direction outlined in the strategic priorities for the healthcare system in British Columbia, we actually will be able to improve care within the budget that we have been allocated.
MRIs. This fall in this House, on a number of occasions, I raised, as did other members of the official opposition, the exceedingly long wait times for MRIs in the province of BC, and some people waiting as long as a couple of years. MRIs, people being told to come back from their MRIs, told to check the year of the appointment because they they would show up at literally the wrong year, and about people even for the most urgent MRIs having to wait twice as long, sometimes 3 times as long as was the standard set by the Society of Radiologists and the national standards in this regard. The ministry announced an increase to the number of MRIs, 65,000 new MRI scans over the next 4 years. He announced that, I believe it was the day after the last session completed. Certainly welcome news for those folks out there who have been waiting exceedingly long time, some of the longest times in the country.
The regional health authorities receive their budgets, larger health authorities like Fraser Health would receive about $2 billion a year. The estimated cost of increasing MRI volumes as planned is about $20 million per year by 2018-19.
The ministry committed last fall, or end of November, for an increase in the number of MRIs that would be performed as the outcome of considerable discussion in this House and elsewhere. By this point in time, the health authorities were to have submitted a detailed plan on how they were going to ramp up activities on MRIs given the increased funding. The first step in the strategy was to maximize unused existing MRI capacity within each of the health authorities. Can the minister please provide an update as to how successful the health authorities have been in utilizing their unused capacity?
Different health authorities took different approaches. Some health authorities had capacity in their system, whereas others utilized private facilities in order to meet that goal. Island Health, which I believe utilized some private MRI facilities, saw an increase, the largest increase of 13.7%.
When we look at CIHI data on wait times, there is information available on wait times for various surgeries and various procedures, but there is no wait time information available for British Columbia when it comes to either CT scans or MRIs. That information is available for most other provinces, but it is not available for British Columbia. Why is it not part of the information that CIHI publishes, and why are those figures for MRI weights not publicly available in British Columbia?
The Canadian Institute of Health Information, CIHI, has agreements with each province over what kind of data is collected. Now, for many data points, those are consistent across the country. For others, they're not. And MRI, CT scan data is one that isn't as consistent.
Which health authorities have contracted out MRIs to private clinics since the additional funding was announced in November 2015? How much is each health authority paying? To which private clinics, and for how many scans?
I don't have the number of contracted MRIs. I know that Island Health is likely the health authority that is contracting the most.
From Health Science Professionals research that they conducted a few years ago indicated that the average cost of a scan in the public sector, that's including all types of scans, ranged from about $200 to $250 per scan. Now, this information is 2 or 3 years out of date, but $200 to $250 per scan, depending on the health authority. Island Health has been paying, we understand, an average of $555 per scan to contract out to private clinics, which is obviously more expensive, especially if the private clinics are doing the simple and the easy and the cheaper ones like the joints. CanadaDiagnostic.com says most single area routine exams, this is talking about MRIs, most single area routine exams cost $900. And then there are various other fees, examples: brain $900, spine $900, joints $900, arthrograms $1,400, abdomen $1,600, breast implant assessment $1,100, and breast cancer staging $1,900.
One of the challenges, and I've had this discussion with some of the leadership of health authorities, is trying to identify what the true cost of any procedure is in our public system. It is much easier to do that in the private system because if you've got a private system, you know what your investment is in terms of the capital, you know what your costs are in terms of the personnel, you know your overheads. All of that is relatively easy to determine. In the provincial public health system, I would challenge any leadership of the HAs to determine the exact cost of any procedure, because it is a complex combination of capital which flows through a different system, overhead which is incorporated in the global funding for the health authority. So it can be challenging to compare the cost per procedure in a health authority versus a private center. It's difficult to have an apples to apples comparison.
I understand that the private clinics that have been contracted to do many MRIs have asked the Minister of Health to consider some changes in governance and in funding models for MRIs as it relates to how these things are, or how MRIs are ordered and charged, specifically as it relates to MSP.
Our system is a mixture, as a member well knows, of fee-for-service. So for some procedures, it is fee-for-service. For others, it is part of the global budgets of the health authorities, so MRIs are paid out of their global budget. There is no, I'm not aware of any current discussion about changing that, the funding for MRIs, switching to a fee-for-service type of model. This is always the challenge within a health authority or any ministry, is looking at the priorities from a patient-centered approach and to be able to find efficiencies within the system to be able to provide those patient-oriented services. In this case, ensuring that we're completing more MRIs within a certain period of time.
Member.
I think we're all aware that the healthcare system has suffered over the last number of years for a shortage of nurses. And in the previous round of public sector bargaining, there was a commitment made to hire an additional 2,125 nurses. The minister made a commitment earlier this year, January the 19th, that after years of delay, it would appear the last of that commitment, an additional 643 regular nursing positions would be created by March 31st, 2016. What is the estimated annual cost of that commitment?
We are still in process, but as of a couple of weeks ago, we were at 1,563, so very close to meeting our goal there. Now, the member's question is, where does that appear in a line item? Well, it would appear, again, under the regional health authorities. We are of the belief that the hiring of additional nurses will essentially pay for itself, because we were in a situation where we were using a very expensive form of filling the gaps, using overtime. And what was happening was clear after we worked with the BCNU and the health authorities that we were seeing very high overtime bills in some health authorities, and we were finding also a high level of burnout on the part of nurses. So we were seeing nurses that were on leave due to either physical injury or from burnout because of the number of hours that they were working to fill this gap.
The trends are obviously very worrisome, and these are the trends are ones that we hear about, the human stories that those statistics reveal, those numbers reveal, that in fact BC's performance in these three areas are getting worse, not better, year over year. A recent study by Canadian Institute for Health Information showed that BC remains second worst in the country for wait times for hips, knees, and cataract surgeries. And in all three of those categories, performance in British Columbia became worse since 2011.
One of the other, or a couple of other factors come into play. One is the shortage of operating room nurses. And this is a shortage that is experienced across the country. We've taken steps with the BC Nurses Union and health authorities to increase the training opportunities for specialty nurses, particularly OR nurses, so that we can fill this gap.
I reviewed the transcripts from last year's estimates and the year before, deciding what questions to ask the minister, and his responses the last couple of years were almost identical. The fact is that the trends are getting worse, not better. Since 2011, things have become steadily worse in each of those areas: hips, knees, and cataracts. And the aging population, the changing demographics that the minister refers to, is not a surprise. This is not something new. We've known about this since the period after the war. So clearly, you know, the long-term solutions are what's needed, and the minister has talked about those, but it seems that not an awful lot has changed in the last few years. In fact, things have gotten worse, not better. Thank you. So to what extent does underutilization of existing OR capacity lead to the wait lists that we have that are getting worse and not better?
It's certainly one of the, I mean, you can't have an OR operating if you don't have the people to operate the OR. In other areas, in Vancouver General Hospital, for instance, a shortage of OR nurses was the reason that operating rooms were underutilized. So if you've got all of the health human resources in place, you're more likely to get to full utilization of your operating rooms. One of the other approaches is that there are some surgeries that lend themselves to off-site operations, and so there are private surgical facilities. The member quoted one paper that was released this past week. There was another paper released that looked at the Saskatchewan Surgical Initiative, which the member praised in terms of the difference that Saskatchewan has been able to accomplish over the last 7 years. And a large part of that was the utilization of private surgical facilities in a way that's very transparent, that is tied into quality objectives with public management and public pay of those surgeries.
I understand that the government has actually had a report commissioned for it, the Esther Sangster Gormley report around barriers to nurse practitioner integration. So 2 questions. Will the minister share that report, first of all? And secondly, what is the government's intention when it comes to developing funding models and potentially new funding models for nurse practitioners in British Columbia?
Yes, the ministry hired a consultant to develop an action plan to identify recommendations for priorities, and that would include issues of NP, nurse practitioner education, and nurse practitioner funding. Those, some of the findings of the report have been shared with the Association of Registered Nurses of BC and the Nurse Practitioners Association of BC to solicit their views on the major themes of the report. My staff informed me that that report is currently being reviewed by ministry staff with the input from the 2 associations, and that they will be formulating recommendations that will come up to me. So I haven't seen the report yet, Honourable Chair, through to the member, and so I await the findings of that report, and we will make decisions on any future changes in terms of education and funding of nurse practitioners once we've had a chance to fully digest and review the report.
So I understand there is consultation happening around the report. Is the minister prepared to share the report that was developed by the consultant so that we don't have to go through an FOI process to get it?
Minister.
Thank you, Honourable Chair. Not before I've read it, so I can't commit to that until I've had an opportunity to review it myself.
There has been some discussion with nurse practitioners and others about population-based funding and the need to expand that model in the province. There are certainly some clinics in existence, not many, but some in BC. One with Dr. Mitch Fagan, as well as UBC's medical clinic, that have employed this model successfully, population-based funding model. And I guess my question to the minister is, this funding model includes involvement of nurse practitioners to a considerable extent. That's one of the things that characterizes it. I have no doubt that one of the barriers that has been identified by nurse practitioners over the years is that our present reliance on fee-for-service model almost exclusively is one of the barriers to an expanded role for nurse practitioners. So is the government looking at a range of options, including population-based funding, to involve more nurse practitioners in primary care?
I think I said in our earlier discussion that there's not one size that fits all, and we've got a system that when Medicare came into the Canadian consciousness in the early 60s, one of the grand bargains of that concession, if you like, by physicians starting in Saskatchewan was the ability to retain the fee-for-service model. It is a model that's very much based in that era, and there are many physicians that have done just an admirable job over many years based on that fee-for-service model. Whether or not it still fits all situations in 2016, I think, most people who look at healthcare policy would concede that it doesn't. So we do have population-based funding as a member mentioned, in some clinics across the province. In Fort St. John, for instance, our team worked very closely with the MLA and with the physicians and health authority in that community to develop a hybridized model that would have some fee-for-service and some population-based funding associated with it. The integrated primary care home that we've been talking about would have elements of population-based funding in some situations as well. So I guess the short answer is yes, there is a willingness to look at a greater use of a population-based type of funding model, perhaps as the chief funding model for primary health care center, or perhaps as a hybridized form, or any elements in between. What we need to do, as outlined by the Auditor General, is to ensure that we have quality measures attached to whatever funding model that we continue to develop. That is a supreme challenge in healthcare. It's a challenge for every healthcare organization that I've ever read about, is how you measure outcomes and understand the value for money that you're getting for the funding model for primary care.
As the minister is aware, when government does fund nurse practitioners through health authorities, they fund the nurse practitioner's salary, but not the overhead. So nurse practitioners who work outside of health authority contracts must pay that overhead themselves. And if they can connect with a clinic, a family practice clinic, and develop a business plan around this that is willing to attempt it, there can be success. However, as the minister is aware, overhead is also expensive. Doctors of BC estimate approximately 30%. So unless nurse practitioners can charge patients, which they can't, they're not able to open nurse practitioner-led clinics because of this significant barrier. What does the minister envision doing in order to remove this barrier?
We certainly recognize that is recognized by nurse practitioners as an obstacle. In some cases, in communities where this has become a particular concern, we've provided some year-end funding to help with overhead. I understand that is not necessarily a sustainable model. So we are waiting to see the result of the consultant's report to develop an action plan around funding. So I'm hopeful that that conversation will continue, but I'm certainly not going to commit at this stage to a fee-for-service model for nurse practitioners. I think we have to review the results of this report, have some discussions with the associations, and come up with some recommendations for the future, but we're not quite at that stage yet.
The last item, number 14, says work with the parliamentary secretary and the seniors advocate to provide an update to cabinet on seniors care improvements in the province by December 31st, 2015. Could the minister please share a copy of that report?
Cabinet reports are under confidentiality, so no, I cannot.
Could the minister please share the substance of the report that he produced for cabinet on improvements in seniors care based on the seniors advocate's recommendations?
Reports to cabinet are covered by an oath of confidentiality. I can tell the member that we are working with the seniors advocate. Our parliamentary secretary is working hard on improvements to services to seniors in the field of healthcare particularly. We've seen the results of some of that in legislation presented here in the House with the changes to the Community Care and Assisted Living Act. And we currently have the parliamentary secretary working with the seniors advocate and with the ministry over the issue of dedicated hours per resident in residential care facilities. So that work is ongoing, and again, we've seen some of the results of that work in legislation passed this session.
My understanding is that there have been several announcements for FirstLink over the last number of years. I believe it was 2007. Perhaps the minister can just give me an overview of the funding that FirstLink has received over time and what the intention is in terms of ongoing funding. Is that going to be a regular funded program, or is it just each year there's a decision made around the table about whether or not to fund this program?
Minister.
Thank you, Honourable Chair. Through to the member. The Alzheimer's Society of BC carries out the FirstLink program, and it provides education and support individuals, services for individuals, families, and caregivers that are affected by Alzheimer's, as the member is aware, as well as other forms of dementia.
Back to the mandate letter. Item 14 in the mandate letter asked the minister to work with his parliamentary secretary and the seniors advocate to provide an update on seniors' care improvements in the province. And I would be very much interested to find out when there will be an update provided. It was to Cabinet is what it says, but I'd be interested in finding out when there will be an update provided to British Columbians.
Minister.
Thank you, Honourable Chair. Yes, we did answer this question yesterday. We don't discuss what we talk about in Cabinet. However, I am happy to share and have shared the fact that our parliamentary secretary, the MLA for Abbotsford, is working alongside our ministry and working with the Office of the Seniors Advocate and with the community that provides many of the services that seniors enjoy in the province of British Columbia.
Mr. Chair, I'm sure the Minister of Health can appreciate that when the mandate letter, which is a public document, says that the Minister of Health is to work with his parliamentary secretary and the seniors advocate to provide an update to Cabinet, that at some point there would be some expectation or some acknowledgement that the public would be very interested, once after got to the Cabinet table, to hear what the parliamentary secretary and the seniors advocate have had to say. So while I appreciate that it's perhaps the first place for that information to go, that it needs to go beyond that, and would like to know if there's any plans to take that beyond the Cabinet table and out into British Columbia.
Thank you, Honourable Chair. Well, I have made presentations to Cabinet committees and to Cabinet as outlined in my mandate letter.
While the minister does say he did report to Cabinet, I think he knows full well that it's not so much that he reported to Cabinet, that I think British Columbians would want to know what was the update, or on seniors' care improvements. So I do believe that when something's in the mandate letter, and while the mandate letter says bring this to Cabinet, I think British Columbians are going to be very curious about, well, what was the outcome of that? Not did he bring it to Cabinet, but what was the content of what he brought to Cabinet? So perhaps the minister is able to answer that question. Not that he reported to Cabinet, but that will there be a time that he anticipates that he'll be able to report out to British Columbians about seniors' care improvements?
Well, we have, as I said, the Office of the Seniors Advocate, and her responsibility includes reporting to British Columbians on the state of seniors' care in British Columbia. So she is doing that. She will continue to do that, and the evidence of what the government, the action the government takes, will be included in her reporting to the public.
The office has been up and running for a couple of years, and so perhaps the minister can, and I know that she reports, she's not a truly independent she's not an office of the legislature, she reports to the Minister of Health. So can the minister tell us what the budget is for this office?
In fact, the overall budget for the Office of the Seniors Advocate in 2015-16, with the professional services that they required, was $3.1 million. In 2016-17, it's estimated to be $4.27 million.
So I imagine there's a work plan set out, and that the budget request is based on a work plan. Is that work plan a public document so people can anticipate sort of what the you know, what's coming up from this office in terms of the kinds of surveys that are going to be happening. I went looking through the website, and I will admit that I didn't dig a whole lot, and generally it's a pretty easy website to find historical reports. But is this anywhere on the website where you can see sort of what's coming, what the plan is, so that the public has, that can access that information?
Not all of that information is currently on the website, but it can be put on there, and we will discuss that with the Seniors Advocate.
I want to go back to the Ombudsperson's report on seniors' care of several years ago, when she spoke of the significant mass replacements of staff. I'm quoting, "Mass replacements of staff can occur when facility operators switch from contracting with one private service provider to another. Such turnovers can disrupt the lives of seniors in residential care, especially those whose care needs are complex. Over time, long-term staff acquire specialized knowledge of these needs, so the simultaneous replacement of many employees can make it difficult for the seniors because continuity of care is disrupted, and this is particularly the case for residents with dementia." And she also goes on to talk about how incredibly stressful this is for families.
I want to again just acknowledge what the member said, that through 2010, 2012, and 2014 collective bargaining agreements and the Bill 29 settlements, both health employers and unions agreed through negotiations to allow contracting out to continue. So I want to stress that this was part of a discussion with the unions, and it was agreed that the ability to contract out would be preserved. The capital is broken into two different areas: restricted capital grants and P3 debt, which is, you know, in many cases a part of capital projects.
The minister said restricted funds and P3 debt. Can the minister give the amount for each?
Minister.
The restricted capital grants are for 15-16 were $378.9 million, and for 15-16 are $505.9 million. P3 debt in 2015-16 was $182.1 million and is $173 million in 2016-17. There was some changes in that we were working with IBM Canada, and in early 2015, the decision was made by the project board and IBM to part ways, and Cerner was retained as a new project partner in July of 2015. We have been working with Cerner and with a consultant in terms of the governance of the clinical systems transformation project, so we have changed the governance to make sure that the work is meeting certain targets and timelines and outputs. So I think that we have a much stronger governance system. One of the key things I think that we learned was when you take on projects like this, there's sort of two ways of going about it. You can bring in outside parties and have them provide advice and leadership when the project is being built, but then they essentially are not there long term. The other approach is what we are doing, which is to encourage ownership of the project by the people who will be using this system over the next 10 to 15 years. And so there's a great, I would say, a greater degree of ownership on the part of clinical leads and others that are involved in helping to design the system.
We know, and the minister knows, that this project has been rife with problems from the get-go. The project was the subject of a risk assessment, as the minister well knows, in March of 2013. one that indicated that 12 of 13 risk indicators were very high. Those included finance, governance, culture, technical complexity, shared vision, resourcing, clinical standardization, achievable expectations and timelines, clinical engagement and accountability, leadership, end user adoption, and vendor relationship. Now, the minister insisted when I asked him about this 2 years ago and again last year, that the risks, quote, fall away as the project moves down the track. Not only, Honourable Speaker, did those risks not fall away, they have certainly come to fruition.
I think it's safe to say that after a period of time, it was recognized that with the provider we were working with at the time, that we were concerned about some of those risks, and one of those risks was governance. So what we did was work with PwC, Price Waterhouse Coopers. It worked with us from July till September of last year, and we made changes to the governance and planning to ensure a program that improves the quality and consistency of what we were doing. As part of their work over the last year, the project team realized that, and this is what I was talking about in terms of the ownership, was to engage frontline clinicians to add clinical elements that will better suit the system needs of the healthcare providers.
This is the third year that I've raised questions about this issue. These issues have been raised in the House in question period. Some of these same issues that the minister talks about now were raised in a report entitled the McKinsey Report, and also in the North York General Report. And when we discussed those in previous sets of estimates, the minister was actually quite dismissive of some of the findings of that report. I think North York General Report was dismissed as, well, this is a huge project and they're just a medium-sized hospital in Ontario, and what was the relevance of it? But precisely one of the issues that the minister has just spoken about, which is engagement of frontline, of the folks involved in frontline delivery in the process, and actually listening to them, not just engaging them, but listening to them, is one of the things that they raised in that report. And they were very critical of the project and of the ministry for not sufficiently listening and listening to people who actually had to use these products in the end.
The reality is that these projects are complex, that no two of them are the same, so you can't just take what happened at North York General, for instance, or what happened at Nanaimo General, and just superimpose it on a very complex organization or group of organizations that we're dealing with here.
Thank you. How many staff were working on this project before IBM left the project? How many are working on it now? How many are health authority employees, and how many are external contractors and consultants?
Well, the number of people working on the project will vary depending on what phase of the project is being implemented. So the current stage that we are in is called the Design, Configure, Validate phase, and currently there are about 300 employees that are from our CST team, and about 50 Cerner associates that are working on the project at the moment. Now, they're not going to be there the whole time, but this is a very intense phase of the project. So there are about 355 to 360 people total that are working on the project at the moment. So even before IBM departed, that number would have gone up and down depending on the phase of the project.
Thank you. Have there been internal ministry documents or internal health authority documents or consultants' reports produced that provide an assessment of why this project has been plagued by problems from the start? And can the minister summarize the findings of these reports?
Well, I'm not going to supply internal ministry documents because well, the member knows well why. That's information that is often used for advice to Cabinet.
What evidence does the minister have that suggests that private hospitals deliver better care than public hospitals?
The question is, what evidence do they provide better performance in public hospitals? There is no evidence that I have to suggest that. And so, the member is wrong in that, in fact, the Shouldice clinic in Toronto has been operating for decades. What we're saying is that the Canada Health Act, despite attempts to characterize it as not allowing the private delivery of healthcare, is absolutely silent on the private delivery of healthcare. In fact, most of the healthcare we get is delivered by business people that are in it for a profit. Doctors do their job for a profit. That's how they make their living. Every time you go to see your family practitioner, it, in many cases, about 70% of cases in British Columbia, is a for-profit business. So there's no ideology at work here. It is looking for the best value and performance for patients of British Columbia. And within the Canada Health Act, it is absolutely acceptable to have private provision of health care, provided it is publicly administered and paid for through the public system, if it is medically necessary.
Thank you. Well, I'm familiar with the Shouldice Clinic for hernia repairs, which was essentially in place before Medicare and therefore was grandfathered. So I do think that's a bit of a red herring because it existed. It's been around for decades, and therefore there have been specific regulatory provisions allowed for that. We already know that private clinics for one-day procedures draw a whole lot of doctors and nurses and other healthcare professionals and serve as a drain on the public healthcare system and are one of the factors, according to studies, that contribute to shortages and to longer wait lists.
So I wondered if the minister can explain why we're going to have the paid parking at that hospital, and secondly, it is a public-private partnership. It is a project agreement that the hospital builds. So I would assume that in that agreement, part of the agreement was the building the parking lot, and that the way that the parking was going to be paid for would be built into the agreement, and therefore would be adopted by the management of this new facility, and that they would be absorbing it. I might be wrong on that, but we do need an explanation, because we have 35,000 people who are very unhappy that while we get a new hospital, they're going to have to pay for parking.
Minister.
Thank you, Honourable Chair. Well, I've provided the explanation in letters to the member, so nothing has changed. There is no such thing as free parking. The member knows that. It costs money to maintain a facility. There's two ways you can do that. You can charge for parking, or you can take it from the budget that is used to provide health care.
The minister will know that in 2014, the Auditor General, for the first time, published a comparison of how much it costs the government to undertake projects on its own compared to using private investment through public-private partnerships for roads and for hospitals as well. And her findings, among other things, she says, and I quote, "As well, it is interesting to note that while the government's weighted average cost of borrowing is approximately 4%, on the $2.3 billion the government borrowed through public-private partnerships, this is 7.5%. And elsewhere in the report, it's noted that that means it is 83% costlier. In other words, the government is paying nearly twice as much for borrowing through P3s as it would if it borrowed the money itself because it is far less expensive, far cheaper for the government to borrow itself than for the private sector. And over 35 years, these projects run the difference in borrowing costs that could run to hundreds of millions of dollars. So my question to the minister is, what lessons has he learned from the Auditor General's report, which indicate that P3 hospital projects are far costlier than if the government were to build it itself? And is the minister planning on building the new St. Paul's Hospital as a public-private partnership?
The member won't get a complete answer because the way projects are financed is determined by Treasury Board based on business plans submitted on each project on a case-by-case basis. So. Two agreements that could have an impact on pharmaceuticals. That's the Comprehensive Economic and Trade Agreement, or CETA, between Canada and the European Union, and the Trans-Pacific Partnership, which is a free trade agreement that includes 12 countries around the Pacific area. The federal government obviously is leading those negotiations, and in terms of CETA, the federal government has said that they are prepared to address any incremental cost impacts to provinces. In the Trans-Pacific Partnership, we have expressed our desire to work with the federal government to look at compensation related to any potential increased drug costs first of all, of CETA. And Alberta is leading a CETA working group with Manitoba and Ontario to look at the impacts of CETA to provincial territorial governments. And so they are working to represent the provinces and territories on CETA and the potential impact it would have on pharmaceuticals. And we would, at the provincial territorial table, work in that same process so that any potential impacts to cost of pharmaceuticals to provinces would be compensated by the federal government.
It is estimated that this could lead to increased drug costs of between $850 million and $1.6 billion annually, primarily because of extended patent protections for drug manufacturers, and the TPP could extend those patent protections for as much as 5 years. And we already know that drug prices in Canada, compared to many other countries, UK, France, Italy, and others, are significantly higher, including outpacing countries like the United States, and we've seen approximately 184% growth in total drug costs. What is this government's position on the need for a national pharmacare program? Not just bulk buying, but a national pharmacare program.
Currently, extended healthcare programs do cover a lot of the costs of pharmaceuticals for many Canadians. Excuse me. And when the member talks about the impact to the public health system of making certain decisions, she would know that there are studies that show that a national pharmacare program would transfer between $5 and $8 billion worth of pharmaceutical costs from the private sector to the public sector. Now, that is a significant amount of money that needs to be found unless there are levers built into the system to reduce the cost of those drugs. And through bulk buying, we are able to get the costs down. But there's certainly no guarantee that instituting a national pharmacare program would reduce the cost to the public system. It may reduce costs to individuals that don't have extended health care plans, I will say that. But it comes at a big cost to the taxpayer. So a national pharmacare plan sounds very good from a sort of high-level, idealistic point of view. But it comes with very real fiscal impacts that cannot be ignored. What I have said, and I think an idea that is getting some traction among health ministers, including the federal health minister, is to look at a common formulary across the country of commonly used pharmaceuticals. And rather than say that we will have a national pharmacare program that covers all drugs, maybe look at the top, let's say, 40 or 50 drugs initially in a national formulary that we all agree on. And that, I think, would achieve some savings without having the enormous transfer of costs from the private to the public. So, you know, there's some work going on to look at that potential idea.
But Dr. Gagnon's report also highlights a savings of at least $105 million to British Columbia with a universal pharmacare program, and even higher savings of as much as $1 billion if the provinces were to, together with the federal government, decide to repeal certain cost industrial policies that in fact have the impact of pushing up prices for drugs considerably.
I think the report did conclude, and I enjoy reading the ministry's reports, that there's, as he notes, there's insufficient evidence to support coverage of CHEIs based on the findings from these 4 studies. I would say this was an interesting process because, as the minister will recall, this process was in many ways kicked off at the initiative of the then Premier, Mr. Campbell. He had a very considerable interest in this area. And the view was that even though the ministry had rejected coverage of this drug program before, that it would be useful to initiate a program that had coverage of the drugs only if it was accompanied by this very initiative. And that's what happened. And I think, I recall when it was announced being quite moved, and I think the Premier himself was personally involved at the time, and he had very moving discussions of it. I make the point about the study because the minister will know that this was one of the studies in the unredacted part of the Comptroller General's report that was described as vague and not being that useful with respect to their report on the health research situation. And so I just want to make the point that this report seemed to be quite on point and quite useful, the 4 studies that ended up being in this report. As the minister said, produced a rate of return for the taxpayers and for the healthcare system, and was a useful and important report. I say that because, and just to ask, because this report was directly linked to the health firings issue, and we're not going to relitigate that today. I think the minister will be happy to hear that. But that this was directly delayed by the health firings issue. I'd like to ask the minister how long it was delayed and whether he thought that had any impact on its value, first of all. And secondly, I just want to explain why I think it's important that the Ministry of Health, which I think is advocating that the report was of value and the initiative was of value, is in this sense disagreeing with the conclusions of the redacted Comptroller General's report. I've only seen little bits of it that say this, and that it's important that he, I think, as ministers, stand behind the report. So I want